So welcome to the Alzheimer's panel. My name is LaTese Briggs, and I'll be your hostess today. I'll tell you why I called myself your hostess in a moment. But I am the senior director here at the Milken Institute Center for Strategic Philanthropy. I called myself a hostess because I want to emphasize that this room is a community. It's a sub-community of a larger community that has an obligation to mobilize against a really important problem, which is Alzheimer's. So, all that said, hopefully you're in the room to talk about Alzheimer's. If you're not, I encourage you to stay, okay? So Alzheimer's is, of course, as we know, it's a global crisis. It's a growing global crisis. Currently in the US alone, there are 5.7 million people living with Alzheimer's. And at the rate at which our population is growing, by 2050, 14 million people will have Alzheimer's. That's an incredibly large amount of people. It's the 6th leading cause of death, and out of the top 10, it's the only one that we have no idea how to prevent it, halt it, or even slow it down, which is not acceptable. In addition to that, in addition to it just being a health crisis, it's also it comes along with an economic crisis, right? So in the US alone, it costs $277 billion to our economy to care for Alzheimer's patients. That doesn't include what caregivers are spending on out-of-pocket costs. It doesn't include unpaid caregiver time. It's just for patient care. By 2050, when 14 million people are walking around with this disease, it will cost our economy $1.1 trillion a year. So I don't know about you, but that terrifies me. You all should be terrified because that's not sustainable. And again, that's just in the United States alone. So that's super sad and, bums me out quite a bit, but there is hope. So I want to take a minute to point to cancer. A couple decades ago, when you got a cancer diagnosis, you were not expected to live beyond 10 years. Only 25% of people who got a diagnosis of cancer lived beyond 10 years. Now, if you get a cancer diagnosis, 50% of people live beyond 10 years, right? And it's because we have a better sense, we understand the science a lot better. We had a better sense of how to treat it, prevent it, slow it down, or reverse it. So my point is that we can get there with Alzheimer's, but it's going to take all of us in this room to figure that out, and we are a node. So my goal and my hope is that you will walk out of this room at the end of this panel and all be inspired to create your own node of a community that'll help mobilize against Alzheimer's. So with that said, I want to introduce my panelists who are all champions for Alzheimer's. They're rock stars, because I said so. They are paving the way to get us there. So to my far right is Michela Gallagher. She's the Krieger-Eisenhower Professor of Psychology and Neuroscience at Hopkins. So she heads up the Neurogenetics and Behavior Centers at Johns Hopkins University. She's also the founder of AgeneBio, which is a pharmaceutical company initiating a phase 3 trial to delay the progression of Alzheimer's and dementia, as well as a late-stage discovery programs for mild cognitive impairment. Next, I have Todd Rainwater, who is the chair of the Board of Trustees at the Rainwater Charitable Foundation. In 2009, Todd, along with his other members of his family, formed the Tau Consortium, which is a worldwide research and drug discovery collaborative dedicated to finding treatments and eventual cure for a class of neurodegenerative diseases that we'll talk about a little later. To date, Tau Consortium has funded approximately $100 million in research around the world, including several treatments currently in clinical trials. This lovely woman to my left is Lauren Miller Rogan. She's an actor, a filmmaker, and the co-founder of Hilarity for Charity. In 2012, she co-wrote, produced, and starred in the film For a Good Time called, who should we call?
Me.
The film premiered at Sundance. She's also, she co-founded Hilarity for Charity with her husband, Seth Rogen, as a way to increase awareness among young people about Alzheimer's. To date, they've raised almost nearly $10 million and have become great leaders in the fight against the disease. She also sits on the board of the California Institute of Regenerative Medicine as the Alzheimer's patient advocate. And last but not least, we have Garen Staglin, who is the founder and chairman of the One Mind Institute. The One Mind is dedicated to curing brain illnesses and eliminating the stigma associated with them. They are really focused on open science and open data. So they are really focused on that to help accelerate improved diagnostics, more effective treatments, and cure for all brain diseases. Over 20 years, One Mind and the Staglin Music Festival for Brain Health have raised about $280 million for brain research. And in his other life, he's a private equity investor with about 40 years of experience. Okay. Only 40? All right. So with that, I want to start by, I want everyone on the panel to sort of tell their story as to how they got involved as a champion for Alzheimer's. So Lauren, I want to start with you. Tell us about your journey and why you're a philanthropist in this space and what you're setting out to accomplish with Hilarity for Charity.
Well, my Alzheimer's journey, I guess, started when I was very young. My grandfather had Alzheimer's disease, my mom's dad, and then my mom's mom was later diagnosed with dementia, which flip-flopped back and forth because the science wasn't there to accurately diagnose her. And then my mom was diagnosed with Alzheimer's when she was 55 years old. And I was 25 and feeling much too young to be facing a parent with that disease at that point in my life, and felt very hopeless and lost and overwhelmed. And eventually, some friends of mine came to me and said, hey, let's throw a fundraiser. We work in comedy. We know comedians. Let's throw an event and raise money for Alzheimer's. So that was 6.5 years ago. And after that event, it became very clear that what we needed to do was become a voice for other young people. Alzheimer's is really considered a disease for older people, yet it affects people of every age as caregivers, as we see our loved ones as they get affected. And so basically we became a place where young people get involved. We have a college program where college students can raise money. We share people's stories, and then the money that we raise goes toward research, which is very important. And we'll talk about it later about prevention, because there are things that can be done at this point. Yep. And the other thing that we do, which is to make a dent in the huge cost of taking care of someone with Alzheimer's, we created a partnership with Home Instead Senior Care and have given away over 200,000 hours of free at-home care, because taking care of someone with Alzheimer's is essentially unaffordable if you don't have an extraordinary job. And that is something that everyone faces with this disease, is how are they going to care for their loved one? So we hope to make a dent in that need.
Thanks. So I have a quick follow-up question. So I recently watched your Netflix feature, which was hilarious.
Thank you.
But what struck me is you and Seth talked about, trying to reconcile between, the sadness that Alzheimer's brings, right? It's a very stark situation with, trying to keep it light to get people to engage. Talk about that process for you guys.
We sort of came at it from a few different avenues, which is one, like I said, we work in comedy. So it was easy for us. My husband has said if we were, chefs, it would be called baking for charity, but we're not. And so it's hilarity for charity. And so throwing events that have sketch comedy and comedy comes very organically to us. As a young person, that's what spoke to me, was being able to take action in a way that was very in your face, very honest, a little less polite, shall we say, a little bit more aggressive. And then the other side of that is that, young people, if they have not been affected by this disease, and it's rare because many people are, I'd say we'd sort of try to trick them into paying attention to it by, dangling some funny jokes and comedians they might like. And over here, they might learn something about a disease that will certainly affect them at some point in the future, and to get them involved in fighting against it, raising awareness, and then also, hopefully one day learning, healthy lifestyles for their own brain.
Okay. So Todd, I want to move on to you. So you were drawn into the world of Alzheimer's through a very different avenue. Your organization is actually focused on researching one of the key biological culprits in Alzheimer's, which is a protein called tau. So for those of you in the audience who aren't protein biologists like me, tau is a protein that, again, is a key culprit in the pathology of a number of neurodegenerative diseases, including Alzheimer's. So this category of diseases where tau is thought to be a key driver is called tauopathies. And you can read more about what tauopathies are in this handy dandy guide here. And I really encourage you to take one and peruse it, because it's not just Alzheimer's. We are hearing a lot in the news about CTE, and Garen is going to talk a little bit about that. But this goes beyond Alzheimer's. And so for those of you who are affected, oftentimes, if you have a loved one or yourselves are with a diagnosis of Alzheimer's, it may not be Alzheimer's. So I highly, highly encourage you to take a look. This lovely gentleman here has a whole stack, so see him at the end. So I'll turn it over to you, Todd, and tell us about your journey and why you're here today.
Yes, thank you so much for having me here. It's an honor. Our family's journey actually began about 10 years ago when my father was diagnosed with a rare form of frontotemporal dementia called PSP. That stands for progressive supranuclear palsy. As LaTese mentioned, it is a tauopathy similar to Alzheimer's, and I'll go into that more later. At the time of my dad's diagnosis, our foundation was very well established. However, we were doing mostly educational research. As we learned more about PSP and about Alzheimer's and about all these tauopathies and how horrible they were and how there was no treatments for them, we decided to move forward and to try to do something about it. So our journey actually began as a search for a cure for PSP rather than Alzheimer's. It's a rare disease, the PSP. But what we've learned over time is that our search for a cure for PSP may actually help unlock the cure for Alzheimer's, and I'll discuss that a little bit more later on.
Thanks, Todd. Michela, moving on to you. You actually lost your mother to Alzheimer's.
Sure.
Tell us about that and how it impacted your path as a researcher.
Well, actually, I was very involved in brain research prior to my mother's diagnosis, and her mother was playing duplicate bridge in her 90s, so it was quite a surprise. This is late onset sporadic Alzheimer's disease, and my own research really has grown against this backdrop of recent clinical trials treating patients with dementia. And the work that I have done has kind of led to some understanding of this transition between healthy brain aging and dementia. And so my interest is in preventing dementia. That is, interventions early enough. It would be sort of like, treating blood pressure so you don't get a stroke, right, or, taking statins so your heart disease doesn't occur. And there is a lot of interest now in this condition of prodromal. It is at least a decade long, where people and their partners or people that know them well can notice that their memory problems, that's sort of central, are getting worse. So it's not just having a senior moment now and then, but it's a more consistent worsening, and that's a condition called amnestic MCI. So we did some research that was done at Hopkins. Clinical research showed of a treatment that would reduce a signature in the brain during this transitional period that is thought to drive both amyloid and tau. And so our clinical trial will be using this treatment over about an 18-month protocol in this condition called prodromal AD. It's an amnestic MCI, to see if we can slow progression. And it's remarkable. I don't know, maybe this is familiar to many of you, but if you can delay progression to a diagnosis of dementia by 3 years during this period of time that takes a decade anyway, so you just slow it down, you will cut the prevalence, that is the number of people with Alzheimer's dementia, by a third. And so that's a big win. It's not the whole thing.
Right.
You want to relegate it to the history books, like smallpox, polio, but that's kind of where my research is. And certainly, I think it's many of us here and many out in the audience have probably been personally affected, because this is not a rare condition.
Right, right. So I want to quickly follow up on something you just said about senior moment. I was having a conversation with someone not too long ago, and it was a very insightful distinction between sort of like as you age and you sort of forget where your keys are, right? That's normal. But versus when you look at your keys and you don't quite know what they're for. That's very different. And so that was really impactful for me because I have an aging mother, and I'm always sort of given the side eye, like, we're good, and she's fine. I mean, she's great. But, for those of you with loved ones, I always thought that was a very important distinction. It's not just a matter of forgetting. It's sort of the confusion that comes along with it. So Garen, I want to move over to you. So you, like Todd, you also entered into the space, the brain health space, through a very different avenues. Tell us about your path and why you founded One Mind.
Well, great. I'm really glad to be here, see a number of friendly faces here. Our journey began in 1990 when, as typical of what happens with adolescents, my son had a psychotic break from schizophrenia. If we knew what we knew now, we probably would have seen it coming, but of course back then we didn't, and it was both a devastating and sobering moment, to say the least. We were fortunate to have the resources and connections to get A, the right diagnosis, B, hard to believe that knowing that your son actually had schizophrenia was a good thing, because we couldn't figure out what had happened to him, but he was basically gone. Having that diagnosis and getting him on the right path and getting him the right medications, he was able to go back to school, Dartmouth, graduate on time with honors in a dual major. But we said, listen, most people are not that fortunate, so we have a choice here. We can run away from the problem or run towards it. And we've been doing that for the last 20 plus years. And our goals has really been to, first of all, reduce the stigma about talking about it, because brain diseases are where cancer was 25 years ago, kind of like the C word, you didn't want to speak it or deal with it. Now's not the time for that. We have cures that work, or we have treatments that work, so people need to access them and do it. And we need to bring a lot more than just government funding to the party. And we also need to bring real translational, business-minded outcomes to the research that is going on. So we've been engaged in a variety of different efforts to do all of those things, from a thing we did with Glenn Close called Bring Change to Mind. You may have seen those PSAs. We now have we're in R&D phase with Ken Burns on a big project to really document the disease. The youth at risk will be the first one of those. We've got large-scale projects now in traumatic brain injury and post-traumatic stress and early intervention in psychosis. And overall, we really believe that, and we chose the word One Mind to name the organization for the very reason that what we learn in one illness may in fact help us unlock the mysteries of the other. And if we can get scientists to share their information and data and stop worrying about their papers and stop breaking down the silos, we'll go a lot faster and not make the same mistakes twice. So open science, collaboration, and the full spectrum of illnesses is where we're focused now.
So obviously, you make a good point. We really need to look beyond Alzheimer's or any individual disease in order to solve for one. And you talked about collaboration, and you touched on the fact that the incentive structure is not really set up well for researchers to share and collaborate. So Michela, I'm going to put you on the spot as a researcher to talk about why is that? Why don't you guys like to work together?
Well, first of all, I'm going to protest that at Hopkins we do.
You do, yes.
We're sort of renowned for being a very, very collaborative faculty with lots of programs across departments, and I work with people in the Bloomberg School in efficiency of clinical trial development, and people in imaging science in the Whiting School. I do think that the traditional model is a sort of a heroic academic. You get tenure by what you are recognized for doing on your own. And I think there still are cultural hurdles to really join what I think is going to be the most powerful way to move forward in science, which is in teams, where you may not always, be able to claim total credit for a product. It's interesting though, so in physics this has not been a problem, because these teams, there's a science article with 300 names attached to it. So there are ways to sort of, push and prod that culture and to get it moving in a bigger direction. But I think that that's what the science needs to have, and it'll happen.
Right. I mean, because the reality is the challenges that we're left with, and not just in neurodegeneration, but across the sciences or across diseases, these ones that we haven't yet solved for, they're really complex. And the only way we're going to solve for them is if we work together as scientists. So Todd and Garen, and I'll let you fight it out for who wants to start first, but as funders, tell me how you guys are dealing with, you know, getting researchers to collaborate.
So we operate under the golden rule. When you have the gold, you get to make the rules. So we have successfully engaged 30 sites, level 1 trauma centers in a 3,000-person longitudinal study on traumatic brain injury, where we took a $25 million NINDS grant and a $20 million DoD grant, and then added $10 million of private philanthropy on top of it to actually do the data curation, FDA, CDISC standards, pay for patient stipends, collaborate on the data, and bring that all together. So those people all had the chance to either fight for individual NINDS grant themselves and do their own 100-person study, or be a part of a 3,000-person study, which in, we would say, 1/3 the time and 1/5 the cost has actually resulted in an FDA letter of support for both a biomarker for blood and for imaging. So as a scientist, if your work is to try to help and change the lives of people, we've proven that working together is a lot better than doing it by yourself. Mm-hmm. We're about to launch a large study in post-traumatic stress that is on the back of a $20 million grant that the NIMH provided, and we're going to put $7 million of private philanthropy to that to do the same kind of things that are necessary to actually create a translational outcome. And we're going to put those two databases together because the comorbidity of TBI and PTS is about 30+%. And guess what? We actually think that this trauma may be the gateway to getting Alzheimer's or dementia 10 or 20 years earlier, and it may also be the gateway as an environmental trigger for other neuropsychiatric diseases. So I think if you can build a big enough tent, which will create outcomes where all the boats rise and everybody, we don't have a principal investigator in any of these studies. We have a coordinating investigator who herds all the cats, and we've developed agreements that we've executed with all of the universities involved, that they will all share on any commercial success equally, and that everyone, all the scientists, gets equal credit for the work, but they all have to agree that at the completion of the study, they have exclusive for a year on anything related to either TBI or PTS. But if anyone else wants to access that data set for exploration in Alzheimer's, schizophrenia, depression, they have to make it available to qualified sources. So it's a process. It takes time. But if you combine passion, dedication, and you have the carrot of the additional money necessary to make the study successful, you can be successful.
Todd?
So I think these days, in general, there's a movement towards including sharing requirements within grants. And we do that, and we're always going to do that, and I think that's a very important thing to do. But I think that one of the things that differentiates us from other organizations is that we try to focus on kind of the softer side of the equation, if you will. And that softer side of the equation, I'll explain a little bit better. My dad was a fairly good businessman, but I think that the thing that he did the best was bringing out the best in people. And he did this by kind of creating environments where people could flourish. He did it by lavishing them with praise. He did it by getting the group to really rally behind a common goal. He was just really, really good at this. And so that's something that we brought to the table with the Tau Consortium, and I really think it's helped facilitate our research. We do this in a couple of ways. First of all, we recruit scientists who not only are impressive scientists in their field, but also ones that we feel kind of can collaborate, people that can work together with that kind of group spirit. And then what we do is we try to foster kind of an environment that makes them feel comfortable. We have 2 meetings a year. At those meetings, it's kind of like a little different than other meetings. We often have them coming up to us and saying, wow, you know, your meeting is the meeting we look forward to every year, because we always try to make it fun. We had an 80s party recently. We have a dance party. We've got all sorts of mechanical bowls, all sorts of crazy stuff.
If you haven't seen a room of scientists dancing, you need to go ahead and put that on your bucket list.
that 80s party was going all night long. My wife was in charge of it, and she did a great job. But you know, I wouldn't recommend this as the way that all other organizations do it, but it seemed to sure work for my dad, and it seems to be working well for us. So that's one of the ways that we try to foster that collaboration.
Mm-hmm. Yeah. So it's a good representation of the saying, those who have the pesos have the say-sos. Right. Good use of that.
We don't say it, but yes.
Yeah.
But I'm going to start saying that.
I say, but that's what it is, right?
My wife says it.
That fits with your theme, right?
like
Comedy, right?
There we go.
Todd's father, I had the pleasure of going to business school with him, and he was not only he was a great businessman, and he did a lot for many people, and it's so wonderful that the family has come together and now is run towards this problem and is doing great work. So couldn't be prouder of you and your entire family, Todd.
Thank you very
Very
much.
good stuff.
So, Garen, your organization is starting another type of collaboration called the Healthy Brain Finance Initiative, which is a social impact bond.
Right.
Can you talk a little bit about that?
So if you read a book by Jerry Porras and another guy called Good to Great, it had in that the characteristics of companies that were over a 20-year period had the best and highest return to their shareholders. And one of the characteristics of that group was their ability to tackle big, hairy, audacious goals. So BHAGs, they were called. So in the spirit of that book, we had taking off the model of Bob Klein, who those of you know him, who did the stem cell bond in the state of California. We've tried to put forward the idea that the World Bank, recognizing the $3 trillion global burden of these illnesses, and the data that you just presented will indicate those numbers are going to go up as the aging populations continue. Mm-hmm. If we could dramatically accelerate research on a global scale, on a collaborative basis, we could bend that curve sufficiently to repay a very significant bond. So we, in collaboration with the World Bank, the World Health Organization, and OECD, and health organizations focused in philanthropy like the Wellcome Trust, are embarking on the exploration of the idea that we could do a very significant bond. The number on the table is $10 billion, and we have a consortium of scientists, including the NIH, all of the members of the Society for Neuroscience, the Wellcome Trust, the Weissman Institute, and others, developing a 10-year plan, which would be the use of proceeds of this bond. So we're in the early exploration stage. We hope to have a product available well before the end of the year. This plan that will be, I think, one of the first ever global agreed health plans that the scientific community will get behind by the end of the year. And if all goes well, we might be able to issue this bond in the early part of 2019. So long way to go, big idea. It's going to take a lot more work. Obviously, the tricky part is the proving of the health economics associated with bending this curve. Mm-hmm. But we're enlisting some of the brightest minds around the world to try to accomplish that. You just think about it, if it's $3 trillion and growing in a 20-year bond or 15-year, that's $45 trillion. I mean, I think we should raise more than $10 billion, because it's a no-brainer that we can't make that curve go down. The trick is proving it or engaging philanthropic sources, sovereign funds that are taking negative interest rates now, to actually either forgive the principal or be able to measure the benefits of closed-loop healthcare plans in their countries, so we can prove that we paid it back. So stay tuned, big idea, more work to do.
Well, that's what we need. We need more big ideas, right?
Yes.
So moving in that direction, so I want to drill down a little bit and talk about where we are in the research horizon. So just opening it up to all of you on the panel, What are the key outstanding questions in the field that if we could answer those questions, we could really make some progress? And what's holding us back from answering those questions?
Could I just say something in preface to that? And that is that, I mean, there is this sense that I'm somewhat aware of, you know, a lack of progress, or why haven't we done it yet? And, you know, it's really, if you understand this in the area of Alzheimer's disease, it was only a few years ago when the NIH budget for cancer was $7 billion, for heart disease was $4 billion, for HIV/AIDS was $3 billion, and at that time it was $420 million was the entire NIH budget for Alzheimer's disease, which is, I mean, it's startling. And there was a tremendous amount of investment in pharma companies at a point where we really didn't understand that much about the complex biology of this disease. And I think it's also really, I think the role of philanthropy is absolutely unique, because you can, you know, sort of steer quickly and sort of grab opportunities, but nothing is going to replace the ability of the NIH to really get behind this. And there needs to be huge public attention and support so that it doesn't, you know, sort of back off. So we're now up to 1.3 billion for Alzheimer's, and it's not enough. I think anyone, and you don't want to grab it from other areas, but this needs, there is a commitment to increment it to get it up there. But that's going to be an important thing to have happen in terms of, you know, the public attention and participation, alongside what I think are brilliant efforts to really take a novel approach and to also try to steer the open science. And industry is responding to that more and more.
So where do we need to be steering the money?
Well, I mean, I think that, you know, we have an example here of a huge commitment to a hypothesis, which was the amyloid hypothesis. And it was hypothesis, okay, that amyloid was an initiator, and if you could just turn that off, you would, you know, stop the disease, maybe rescue conditions, and so far that has not proven to be the case. And the definitive study for the amyloid hypothesis is going to be in some of these small trials in autosomal dominant early familial genetics. Because you can actually start treating people. You know the age at which they will begin to accumulate this pathology. You treat them before that. You don't treat someone with dementia with those products. So, you know, that there has been a sort of, it's been a single approach. And everyone realizes that we need to broaden approaches, and there's going to be some period of time advancing new ones. But I think that should be encouraged. And I think there should be a lot of attention to what they call Death Valley, which is the ability to take the basic science, the preclinical data, and then really demonstrate the proof of concept in humans. That was the bridge that we crossed that was really quite striking at the time, because you could see it in many of the Alzheimer models, and then see the same thing in humans in terms of the localization of problems and how you would treat them.
So Lauren, you guys are funding research as well. You want to talk a little bit about that?
Yeah. So to your point, you know, we are trying to now focus on, you know, we don't raise millions of dollars every year. We're somewhat young in our growth, and while we do make a good chunk of change, we're not going to be funding the research that will find a cure or treatment. So what we want to do is focus on taking the small steps that we can achieve. So much of that is education, which then will lead toward, hopefully, prevention. There is so much great work being done these days in the areas of prevention. We just funded research through a doctor at Weill Cornell in New York who runs an Alzheimer's prevention clinic. And the majority of his patients are excuse me, in their 20s, 30s, 40s. I'm a patient in his clinic and have done full genetic workups. I then have very specific instructions that are based on my personal genetics, diet, exercise, supplements, et cetera, in addition to cognitive testing. So I have a baseline of my cognitive ability to market as the years pass. And there are so many things being done to assess personal risk and then figure out how do you live a healthy lifestyle, a healthy brain lifestyle, so that you can prevent the disease, whether you delay onset 3 years, 5 years, 10 years, or altogether.
Wow.
You know, we've done a lot of work, we, the scientific community, in what are called positive feedback loop computer-based systems. There are now 800 apps that are available to you as individuals that actually have proven very positive effects, particularly in the process of kind of delaying the dementia part of memory. Right now in this room, we're all creating new neural pathways as we listen to this conversation. And so taking advantage of that, you can actually do rewiring, basically, or muscle building your brain to do that. And I think this is another area that we've talked about prevention, or that could actually help you find your keys and do that. A lot of theories said if the most important thing you could do before was learn to play a musical instrument or take a foreign language after you get past the age of 50. This is another way to go about doing that. And on our website, we've actually employed a team of scientists for a part of our site is called Cyber Guide, and we've actually reviewed over 100 plus of these apps for their therapeutic effectiveness and where they might be appropriately looked out for people. So I encourage you, if you're interested in that, PSYBER, Cyber Guide. And there's very interesting stuff, and it's had very strong outcomes. My son used it for his recovery in schizophrenia, and my wife, when she can remember, does the app every day. Yeah.
Karen.
And I do too. I do too. She told me to say that, but anyway. Okay.
But I want to add that it's important to do those things before 50.
Yeah, that's right.
That these changes in our brains, you know, I'm 36. Like, you know, my mom was diagnosed at 55. So chances are, if you were able to look at her brain when she was 36, there were likely changes already happening. And so that's why it's important to live a healthy lifestyle always.
Right, right. So my team and I, we often talk about precision health, and so it's really exciting to hear, you know, the approach that you described, where there's a whole clinic dedicated to patients who are in who do not have Alzheimer's, and they're establishing a baseline, and that there's, you know, tools and resources to help us figure out, you know, what's good versus what's junk in terms of digital apps. So that's really encouraging. So I want to continue to talk about the role of philanthropy and investment. And, you know, to your point, even if you aren't investing millions upon millions upon millions or billions of dollars, which we do need a lot of money, but it's about how you invest, right? It's all about your strategy. And so, in thinking about that, going back to a point that you made when you were talking about sort of the role of pharma, recently, pharma giants like Pfizer have recently announced that they're defunding their neuroscience programs, due in part to large clinical trial failures in the neurodegenerative space. In Alzheimer's alone, the clinical trial failure rate is 99.5%, which, as a scientist who is used to failing a lot, that's an enormous amount of failure. So that said, even if we focus on, you know, move the needle questions, et cetera, prevention, you know, new therapeutic targets, how do we get pharma back into the space to develop? Let's talk about how we actually de-risk for them.
Well, I think a lot of these trials, you know, I'm obviously a little bit biased being the Tau guy up here, but I think a lot of these trials have failed because they've been focusing on the wrong thing, because they've been focusing on plaque. And I'll just interrupt. A lot of the patients in these trials don't actually have Alzheimer's, right? Correct. It's been hard to diagnose them without a real way to do it. One thing that we're working on is a tau PET scan, be able to image the tau in the brain. Right now you can go down and you can get an amyloid scan, the amyloid scan, and it can say whether you have amyloid in your brain, but it doesn't necessarily mean that you have Alzheimer's. There's a lot of healthy people with amyloid in the brain. There's an analogy that says that the amyloid is actually the gun, but tau is the bullet. Once again, I'm a little bit biased, but I really believe that the tau is the main culprit in this disease. So I think we need to begin focusing a little bit more of our efforts on tau. And I think most of these companies, that, people say that they're getting out because they have no hope. Well, I think they're getting out because they spend all their money on tau, and the company's kind of given up on them. Pfizer's kind of given up on them and said, okay, well.
Amyloid, yeah.
Amyloid, thank you very much.
You're supposed to be the tau champion.
Exactly. Sorry, doing my best. So anyway, but there are companies, AbbVie, we've put a lot of money into one of their anti-tau antibodies. Biogen's doing some great job with their anti-tau antibody. They've also got an ASO in the pipeline that they're working on. And I think that the best idea, is to focus kind of on these kind of newer cutting edge companies, and that's something that we're trying to do at least.
And for the audience, so PSP is actually, it's a standout in that it's what's called a pure tauopathy. So in this class of neurodegenerative diseases that make up the tauopathies, you have a couple different ways you can slice it, right? So you have the category where it's just tau, and you know that that's the driver. And then you have a category where there's a mix, but there's a high prevalence of like amyloid and a little bit of tau, et cetera. And then you have it's just a smorgasbord of stuff, and you don't quite know. So with PSP, because it's a pure tauopathy, running studies on patients where you're just able to focus on tau, you have a very homogeneous data set. And so it's not, it tells you more. So you're not fighting against as much noise as you would in particularly Alzheimer's trials, where, again, there's 100% certainty that everyone even has Alzheimer's. So I just wanted to make that point for the group.
And believe it or not, I'm sorry.
No, go ahead.
I was just going to quickly say, believe it or not, in the end, a lot of people say, okay, why is this guy up here talking about tau and PSP and all this stuff? And a lot of people here are for Alzheimer's. And I would say to you, actually, believe it or not, it's actually probably ultimately the first anti-tau drug for Alzheimer's, which I believe will be the first drug for Alzheimer's, will almost certainly be approved through a PSP trial before it is approved for an Alzheimer's trial. And the reason being, as you kind of alluded to, these PSP trials are both quicker and cheaper to do. The patients are younger, so less confounding variables, as you mentioned. Also, the disease is much more rapid, so you can kind of do the trials quicker. And finally, PSP, since it's a rare disease, you can kind of get that orphan drug status, so you can kind of push it through. The rules are a little bit more lenient in terms of pushing those through. So I think, once again, for the Alzheimer's community, PSP is kind of, progress in PSP is what they're looking for.
Yeah, and I was just going to add, and I think that's the gun and the bullet, or whatever the analogy is. But there's also, one of the reasons that amyloid got so much sort of energy behind it is that the genetics for Alzheimer's disease were pointing to amyloid. And there wasn't any pointing towards tau on the genetic side that allowed models specifically for Alzheimer's disease. But there is a rare variant of tau that can cause Alzheimer's as well as pure tauopathies. And I know the Tau Consortium has been funding some of this, and I think it's incredibly important to look at the interactions between these pathophysiological pathways to understand what that biology is, because it is very different in Alzheimer's disease, the systems affected, and the pattern of progression, and even the underlying pathology of tau may differ across those diseases, so that it could be that there would be a therapy in a pure tauopathy that would work in AD, but it could be that those would require different different targets.
The 3 and 4.
Yeah,
right,
absolutely,
right.
the 3 and 4. Right.
I'm a little more.
I would just say that I think pre-competitive IP is one of the ways we can bring them back. This idea that you could own 10% of the watermelon as opposed to 100% of the raisin, which is the way it's worked out on a lot of CNS, is I think an important project, but it takes very large-scale projects. I mean, I happen to have the privilege of being working with UCLA in a 100,000 person study on depression, and I know that's going to bring a lot of people to the party once we get identifiable targets. It's the lack of targets that's really holding us back. We don't know how to say it's working or not working. We have impacts on positive or negative symptoms. We do have better and better imaging technology, and now we've got the genome. So there's a combination of things that will ultimately get us to targets that would allow us to get people back. But without scale, because we have a lot of non-replicatable studies that have been done, which you can't, we've cured a lot of mice, but no people with a lot of this. So it's an important element here. And one other thing we're trying to do is to create some tax incentives through, seems like the one thing Congress can do is pass tax reform. So we actually have a bill that's being written out of the House Ways and Means Committee, which we're going to provide a 50% tax credit for all new neurological research, particularly if done in consortium models. So that bill will get on the floor in the next 3 months or so, and probably when the Tax Reform Act next year has to be ratified, because all of your personal deductions are going to go away next year. They won't let that happen. So we may get that passed next year, which could be another way to give more economic incentive. But if you don't have pharma, you don't have VCs, you don't have early stage businesses, and that's a bad way to run development.
Yeah. So Todd, you guys are running a crowdsourcing, you're using a crowdsourcing platform in an innovative way. You want to talk about that? Are you ready to talk about it?
The Rainwater Prize?
Yeah.
Yes. So in 2009 when we founded this, we were really shooting to do basic research kind of into this disease, try to figure out some way to find make progress and find a cure for my dad. But as time has gone on, we've kind of changed course a little bit and expanded our horizons to try to spread awareness of tauopathies and also to move these drugs forward. The one thing that I'm actually really excited to announce today, and you're actually in on a secret here, you're the first group that we publicly announced this to. I've got Pat's blessing that we can kind of reveal this. We're actually going to be launching the largest brain prize in the world soon. It's called the Rainwater Prize, and my dad was not about putting his name on things, and he probably wouldn't be completely happy that we're putting his name on it, but I feel very honored that we are. And what it's going to do is going to award accomplishments in the tau field. A multi-million-dollar prize will be given away to the first researcher or researchers that discover the first FDA-approved treatment for a tauopathy. And then we're also going to have annual awards given out in smaller amounts for advancements that we kind of specify ahead of time within tauopathy. But I think the whole goal of this is to kind of spread awareness of the tau field and about tau research and how it's related to Alzheimer's, and also encourage young scientists to get into the field. So it's a really exciting thing.
Yeah, it really is.
Absolutely.
So we'll take questions in just a second, but I want to recenter the conversation around the humanity of this issue, because there are people who have Alzheimer's right now who are suffering. There are families, loved ones, and caregivers that are struggling. And so, Lauren, your organization is really focused on the human component of this. So part of your central mission is bolstering care and supporting caregivers. Talk about why you're so focused on that.
You know, my dad is my mom's full-time caregiver, but I would say that I had a pretty front row seat to taking care of someone with Alzheimer's disease. And it is a 24/7 emotional and physical job to take care of someone as they advance through the disease. And, you know, had we not stepped in and had my family not been fortunate enough to be able to afford care, we would have lost my dad before my mom. And, you know, my dad felt, you know, very firm in the choice to keep my mom at home. And so many people aren't able to make that choice. They are forced to put their loved ones into facilities that are less than they would like to, because quality facilities are often unaffordable. And of course, at-home care is extraordinarily expensive. And so we wanted to find a way to help people today in extreme circumstances by providing care to people and paying for at-home care We can't help nearly the amount of people who apply for care. I would say we often focus on the earlier onset. 15% of caregivers are actually under the age of 40, which is a pretty shocking number when you consider what you imagine an Alzheimer's caregiver to be.
Right.
And that's a really, when you really sit to think about that, that's people who are in college, sometimes in high school, who are starting young families, starting careers, who can't. We awarded a grant to someone who wasn't going to be able to go to college because she had to stay home and take care of her mom. And we couldn't give her the care that she could go to college, but she could take classes.
Yeah.
And so becoming an advocate, not just for more research money, but for care money, for support from the government, is, as you pointed out, these numbers are growing. When there are 15 million people walking around with Alzheimer's, well, they won't be walking is the thing, as they get more advanced. We will have a real issue on our hands if we aren't also tackling the issue of care.
Right, right. So one of the things I love is that sometimes you are actually the one to make that phone call to tell people that they've gotten this grant.
Yeah, we've done that a few times.
Share that experience.
When someone is really in it, when they're really caring for someone with Alzheimer's, they often don't get to go outside. They often don't have time to go to the bathroom. They don't have time to take a shower. We had, early on, one of the grants we received, I remember given away, we received a thank you note where someone, he literally said, thank you for the chance to join humanity again, to get to go to the grocery store as a gift. And so, it's been a real eye-opening experience to touch people's lives in this way. And so another story I'll share, and then I'll get to the phone calls, is my husband was on a flight and a woman came up to him and said, I wouldn't be on this flight if I didn't have one of your grants. I mean, people cannot live their lives when they are doing this. And so we have sort of gathered around the table to call recipients sometimes to tell them that their lives are going to be changing, that they're going to be getting 25 hours a week to go to the doctor. Someone one time thanked us because they were going to get to go to a funeral. It's such an extreme thing, and we've been fortunate to directly affect people's lives in that way because we're helping people today through care. But that's not to say that the research isn't, should go hand in hand.
Right, absolutely,
It needs
absolutely. So I want to open it up for questions if I can. You had you wanted to ask a question like 5 minutes ago.
Thank you very much, all of you. This is really fascinating. I have two quick questions. One concerns tau. I'm an outsider scientifically. I'm just learning about this. When I listen to you talk about tau, I'm listening to the talk of cause. Are we sure that tau is the cause of the disease, or is it a symptom of something else, like the brain's immune system overreacting to other types of inflammation? That's question one. Question two, for Dr. Gallagher in particular, my name is Daniel Arbes, I'm sorry, I should have introduced myself, is when we talk about therapies, every bit of every conversation that we've listened to for the past hour has been about molecular therapies. Should the process, talking about rewriting the playbook, expand to include non-molecular therapies like optogenetics and other things that are underway?
Right. So do you want to take the tau first?
Sure, I'll do my best. So first of all, I'm not a scientist, so I'll do my best to answer this. It's a very good question. It could, for example, Alzheimer's. The Alzheimer's, they said that it was plaque, and then some people say it's tau, other people say it's inflammation. I believe one of Garen's researchers found something recently. It's microglia. It could be involved with microglia. There could be multiple reasons for Alzheimer's. We are obviously biased being the tau consortium, so we probably tend to get the people that believe in tau a little bit more. But if you take something like PSP, I think it's fairly well, we're fairly confident that it's a pure tauopathy, so it's almost for sure caused by tau. But it may not be. But if nothing else, we'll reveal through our research that it wasn't tau, and then we'll change to becoming the microglia consortium or something like that. And I'm happy to do that. but we haven't been proved wrong yet.
And that's also the power of philanthropy, right? Being able to be nimble, right?
Mhm. Oh,
So
yeah.
being able to shift and say, you know what, we were wrong, it's not tau, let's
Yeah.
steer the boat.
I'm
in
going to
this
continue to be
direction.
cocky and act like it is, but it very well may not be.
Michela?
So actually, I love your question because, I mean, Alzheimer's disease, you know, really travels along specific neuronal phenotypes in the brain and pathways and spreads, and it's got its own sort of topography or map in the brain that it follows. And during progression, and it's very, very slow progression over decades. And so what we've been working with is a key idea that in basic research, it's, I think, very well established that neural activity drives both amyloid and tau. And in this condition that lasts a decade of MCI, there is heightened neural activity in the specific circuits where it's originating and spreading from. You can image that. That's what we did. And then we took a drug to lower that activity. And it was there was a big insight because when people were seeing the overactivity, because it's in the memory system, they were conjecturing, oh, well, this is compensatory. The brain is struggling to make memory, or is making, this is beneficial compensatory. If you bring it down in MCI patients, the function of that system improves. So it's part of the problem. And then if you put alongside that the fact that the overactivity can drive amyloid and tau, then crank it down. Just crank down the overactivity, and maybe whatever is happening along those pathophysiological pathways, whether it's this specific tau molecule or that specific amyloid oligomer, you may be able to slow it down. So that's our approach. And it is very much a kind of brain network approach rather than this is the bad molecule.
About a month ago.
Can you say it into the mic for the video?
Oh, hi. Hi, I'm Elizabeth Scharf, and about a month ago I read an article in the Times that asked the question, what is the best long-term care for aging boomers who have Alzheimer's? And the punchline was conscientious daughters. So, I mean, the fact of the matter, a lot of the care is going to go to the conscientious daughters, and what's different about this generation of conscientious daughters is that most of them are working full-time. So we talked about investment and on the prevention side and the research side. Have you, Lauren, or others here seen any places where we should invest in the care side of things? I mean, clearly haven't figured out child care. Are there experimental models in care for aging parents or other things where we can put investment in philanthropy?
You know, the reason we created our own program to provide care was because we couldn't find a model to invest in. You know, I'm not up. I can't spout facts about what the government is funding, but there's no caregiver money out there. There really aren't models. There are a handful of, you know, organizations like ours who are approaching things like us. But I'm not trained in creating policy, but in my opinion, we should be advocating to create a large long-term care plan because, as we've said a few times, as this grows, the conscientious daughters are busy. As I said, 15% of caregivers are under 40. They are busy, and they're not living their lives. They're not paying attention to their families. They're not getting the opportunity to grow their career. And so at this point, it is the conscientious daughter, and there is nothing, which is why we created our own program.
There's a lady named Marilyn Comer who's done a lot in care. She personally is taking care of her husband, and I think she has another relative now. So she's done a lot, I think, and I would be someone to connect with. I can help you make that connection.
And then maybe you can pass it down to.
Sure, thank you. Yes, my name is Amir from X Prize. I had a question. You hinted on open research and collaborative research. Yes. What are the main obstacles today, whether it's the diagnostic therapy, that you think could be resolved with more collaboration and more open platforms? The question is clear.
Well, I think scale is the most important reason to get to open science. So in this study that we did in traumatic brain injury, a individual level 1 trauma center enrolling enough patients to get to 3,000 people would have taken 10 or 15 years to do that. So getting different phenotypes across the country with different age and ethnic populations also helps through the collaborative process itself. So I know, and speaking from what the advantage that the UCLA healthcare system has, you see 2 million people a year, or 1.9 million people a year. You have almost your own ability to build a large cohort in a quick time, which is the thesis behind this depression grand challenge that's underway there. But I think it's about getting to scale quickly and getting these different phenotypes, and then having the opportunity for insights that will come from the work that each individual scientist is doing and provoking and tapping each other. And while within any university there's great collaboration, I think there's nothing better than multi-university collaborations. So
get the scale. And actually, I mean, for some of the wonderful things that that you're doing in other populations, the Alzheimer's Disease Neuroimaging Initiative has been an open source, and the reason why we understand so much about the right patients weren't enrolled in that clinical trial, or what we could do to prevent Alzheimer's disease, is because an enormous database that has been collected over many years now in the Alzheimer's Disease Neuroimaging Initiative, and that was a public-private partnership between NIH and industry that founded it. And it's spread all over the world. There's ADNI Japan, ADNI Australia, and the great value in that data set, and you can sign up, become a member, and have complete access to it, is that you can model clinical trials by selecting the people who would enroll, you know, and then following them up over time for a number of different endpoints. So it has really, we understand more now about who to recruit, when to recruit them, for what therapy. And, you know, with Alzheimer's disease, it's a very big spectrum, and, you know, you need to understand who to recruit, when to recruit, and how to treat them.
So we have time for one super fast question.
So,
Sorry, Mark.
So I've got the mic, I get to do that, right? So, I'm Mark Roithmere, I'm the CEO of the Alzheimer's Drug Discovery Foundation. First of all, to Milken, thank you for this panel. To the panelists, you guys phenomenal, each and every one of you. And then we take particular pride in Dr. Gallagher, because she's one of our grantees. And it's more of a statement and maybe an answer to another question or two that have been asked. So ADDF was founded by the Lauder family, Leonard and Ronald Lauder, to just solely be in the valley of death, to look for those molecules, to take them phase 0, phase 1, phase 2, right? And quite frankly, we've never been more optimistic. And there was always this, we stopped funding anything with amyloid in 2011 because Big Pharma came in to take it over. And we always saw it as, it's going to be incremental, but it's not going to be the be-all, end-all. And from our perspective, that optimism comes from, there's like 5 things here. 1, you know, we need a simple blood test to diagnose Alzheimer's, and we're getting on the road to do that. 2, and we've heard it today, we need more and better biomarkers, because how one person presents isn't going to be how another person presents. Big one for us, targeting the biology of aging. So if it's plaques and tangles or tau, what else is going on? Inflammation, vascular, issues like that are going on. The final 2 are, you know, we need well-designed clinical trials. We have an elderly population, not an easy thing to do. And the last piece, and we take the book out of the page out of the Book of Cancer from 20 years ago, combined therapies. Ultimately, we believe it's going to be precision medicine, combined therapies. And I'll say again, we've been doing this for 20 years. We've never been more optimistic. We see this in the runway ahead of us now.
Yeah, and I'd just like to thank you, because they have a program called Program to Accelerate Clinical Trials that also gets you over that hump of getting clinical data for proof of concept, which is really important.
So that's a great place to leave it there, but I do actually want to give Lauren one more task.
Okay.
Charge the group.
Oh gosh, okay.
Do it.
I'll say this, none of this happens if Alzheimer's stays a secret. So as you touched on early on, where cancer was 20, 40 years ago, people whispered the word cancer. The only reason that has changed is because they stopped whispering it. It appeared on TV shows, movies, conversations. People told their stories and came out of hiding. Alzheimer's, people are still in hiding. Without without everyone getting behind the fight against brain disease like they have, and I'll give the example of breast cancer. I mean, my blender is pink. You know what I mean? Until
my debit card is pink.
And until your debit card is purple, and Alzheimer's really is getting the attention that it needs and deserves, we're going to stay where we are. And I think that it has grown tremendously just since I've become an advocate in the last 10 years, and certainly I'm inside of it, and so I'm more aware of it. But I think that my most simple charge would be to tell your story if you've been affected, and to listen to someone who's telling their story if you have not, and then take action by sharing that story on.
Thank you.
Oh, thank you.
So let's turn the world purple, okay?
Absolutely.
Light it up purple.
By visiting our website, hilarityforcharity.org.
Thank you.
Yeah, that's right.